A very good morning. This is Dr. Wazir, Senior Lecturer from the School of Computing and Technology, Asia Pacific University. A very warm welcome to everyone to join our first webinar for the day titled Application of AI in Medical Imaging. It's a great pleasure to welcome Dr. Shiba to share her valuable knowledge and experience, who's a postdoctorate researcher in this field. Very warm welcome, Dr. Shiba.
Thank you, Dr. Wazir.
It's a great pleasure to have you here, Doctor.
It's a great pleasure to be with you and your students today.
Thanks a lot, Doctor. Thanks a lot. I'm sure everybody is eagerly waiting to know the details and the in-depth knowledge of medical imaging and AI. So I don't want to take much of your time, Doctor. So we can straight away go on to your presentation. Yep.
Sure.
So your slides, Doctor, please. Yes, Doctor, your slides are being presented. Please go ahead with your presentation, Doctor.
Okay, thank you, Dr. Wazir. Hello, everyone. A very good morning to all of you. And I'm really happy to be here presenting my research work based mainly on artificial intelligence and medical imaging. A short summary about myself. I am Dr. Shiba Jennifer Sujit. I'm a postdoctoral researcher in the Department of Imaging Physics at MD Anderson Cancer Center. To go in depth about the research projects, I want to briefly talk about the Texas Medical Center itself. Currently, we are in Texas, and Texas Medical Center is a very old and very established medical center. It was started in 1900, and it is the largest medical city in the world. So some of the facts and figures about the Texas Medical Center. As you can see, this is the world's largest cancer hospital. The MD Anderson Cancer Center is located in the Texas Medical Center. And the world's largest children's hospital is also in the Texas Medical Center. And about 8 million patients visit every year. And there are about 180,000 surgeries that are being carried out in the medical center here. And as the statistics show that there are about 9,200 patient beds available here, and about 25,000 babies are delivered per year, and about 13,600 surgeries are done, and total number of employees is more than 106,000. So it's a very large medical center. Why I want to highlight this is that it's a gold mine of medical data. So you get a lot of data, medical imaging data, and in this medical center, and it's a very hot spot for medical research. And one of the important highlight is the 2018 Nobel Prize Award winner is from MD Anderson. He's an immunologist, Dr. James P. Allison. He won the 2018 Nobel Prize in Physiology or Medicine for his discovery of cancer therapies that stimulate the immune system to attack the tumor cells. So his discovery was mainly based on using our own immune system to fight back the tumor cells. So this medical center is a very rich center with a lot of member institutions that work together to promote the high standards of patient care, research, and education. So I have listed few of the member institutions here. These institutions involve different healthcare systems, hospitals, and universities and research centers. Every kind of research work together for improving the patient care and medical research in Texas. So having given a brief introduction about the Texas Medical Center, let me go straight to our topic. So, why medical imaging is so important? As we all know, the saying which goes, a picture is worth 1,000 words, right? So, I have given a small example. So, if I just say flowers, we don't get much information out of it, right? But when I show you this picture, there's a lot of information hidden in this picture, right? There's different contrast, colors, shapes, texture, right? There's variation of information. So that's the same thing we expect in medical images. We have a wealth of information or the patient information hidden inside these medical images, which help us to improve patient care and improve the diagnosis or improve the survival of the patient. So, what is medical imaging? It's the process of using various technologies to view the interior of the human body in order to diagnose or monitor or treat various medical problems. There are various imaging techniques. You might have come across some of these imaging in your day to day life. Some imaging techniques include X rays, magnetic resonance imaging, often called as MRI, or CT scans, or PET scans, or mammography for breast cancer detection, and many more. So, these are the different radiological imaging techniques that are available, which can help us to acquire the innermost part of the human body. So here I have shown some examples of medical images, what I have previously used for many of my experiments. So the first image is a CT image showing a cancer or a tumor highlighted in red color in a lung cancer patient. So you can see the lung region and the tumor part is highlighted as red color in the figure A. The second figure is again a CT image, but this is an image of a COVID patient. Now, if you can see inside the lung region, you can see the infections in the lung, which shows the patient is positive of COVID-19. And the red and the green color shows the right and the left regions of the lung that is being segmented using one of our segmentation algorithms. So the third picture you can see it's a mammogram image of a breast cancer patient showing dense benign tumor in the breast. And the fourth image is a brain MRI image of a multiple sclerosis patient. Now you can see the pink colored dots are nothing but some of the lesions that are present in the image. So by visually checking itself, you have a lot of information saying whether the patient has tumor or not, whether the COVID patient, the lung is infected or not, or the mammogram has dense benign or malignant tumor present, or how dense it is. And you can also see how is the distribution of lesions or how big is the lesion in a brain MRI. So any patient can diagnose with the disease, can do imaging, and a lot of information can be gathered from these medical images. So day to day in my lab as a researcher, I work on these CT images and PET images to closely look at the diseases that are highlighted in these images and use algorithms to either predict disease or diagnose or classify or segment these images. So what is the role of AI in medical imaging? As I said, medical images are a rich source of information, but it is very tedious for any human or a radiologist to go through all the scans and read or interpret those images. So we need automated systems like AI to automatically recognize complex patterns in imaging data. So some of the examples I showed you earlier, there are some patterns which you can see that is repeated in the same disease or the same kind of patient cohort. So recognizing these patterns cannot be done manually. We need automated systems to recognize these patterns. And the next important role of AI is how do we measure these characteristics or how can we quantitatively assess these characteristics. So for example, if I say there is a tumor in the image, how big is the tumor? What is the diameter? What is the radius? Is it bigger than before surgery, or has the tumor shrinked after any kind of treatment? So there should be some kind of measurement we need to have so that the radiologists or the doctors can make better clinical decisions, which is very difficult to assess visually. So the third important role of AI in medical imaging is we can extract large number of features, like as I showed you in the previous picture, there are shapes, there are textures, there are different volumes of tumors, and the distribution of contrast in each of the pixels. Or you can even specify some regions of interest. Like for example, if you want to just concentrate on the tumor region, how can we extract these features from those images? So we need some automated systems to do this. And latest techniques like deep learning, right, learns automatically, right? You don't have to handcraft any image features, but deep learning techniques learns from large amount of data. They extract information from data. So deep learning plays a very important role in processing or predicting diseases in medical images. So some of the common applications are, we can either use these kind of features to classify whether the patient has tumor or not, or whether the COVID patient has infection or not. Or you can even segment, as I showed in the previous example, you can just segment the tumor region, or just can extract the lung part of it, or you can just extract whatever regions of interest for your problem. So you can detect abnormalities, or you can predict, like this person is going to have this kind of symptoms after 5 months. So you can even predict diseases even before it is happening, just by seeing the patterns that has been happening in the previous scans. So much of role machine learning or deep learning or AI can do in medical imaging field. So to continue, AI improves the entire radiology workflow just from acquisition, right? So just when the image is acquired from a scanner to images reconstructed, you can visualize the images, how to analyze, detect, and even for treatment prognosis, AI plays a very important role. So I have listed 5 points, and there can be many more advantages of AI in medical field. So as I told you, because we can precisely quantize the features, we can detect the cancer in a very early stage. Even when it is very small, we can detect cancer in its early stage. And certainly early detection helps to improve the chances of survival. The patient can live longer, and the treatment can be precisely aligned for the patient, because if you can detect cancer early, better and faster treatment can be planned. And we can quickly identify high-risk patients, right? If these are the features, then this treatment is not going to be useful for this patient, or this treatment will help this patient. Or in other words, I can say precision medicine is possible, right? It's not that the same treatment is given for all the patients. Because of this techniques, you can plan the treatment for each and every patient. And it also improves the productivity of clinical workflows. So today, the papers, what I'm going to discuss is mainly focusing on this productivity of clinical workflows, how AI can help in the smooth running of the workflow. And the another advantage is improved patient experience and outcomes. Yes, so we have patient care, and better outcomes will help better life for the patients. So there are many such advantages of AI in medical field. So as a nutshell, I can say this can be an overall pipeline of any AI system. So if you are working on a project or a research project, So we plan different stages, right? So most of the stages or the process fall into all these 5 categories. So the first stage is acquiring the image itself. As I told you, we are in the medical center and we have access to real-time patient data. So once the patients are diagnosed in our hospitals, our universities are built with hospitals, so we get patient scans, the MRI, the CT, and the PET from different clinical trials happening in the hospitals. So we get and the images are in a system called PACS, right? Picture archive systems. And the first process is to acquire these images from different resources. And as you can see that these data is not in the right format, right? They are not ready for any processing. So these data have to be converted to different formats. See, for example, for training machine learning or radio deep learning models, we usually want the scans to be in the Nifty format, whereas the raw data is in the DICOM format. So we usually do the conversion. And then if I'm going to work on the pre-data, which means the scans taken before surgery and after surgery, so I need to register them. There is a registration process, which means that they all fall in the same plane. So we need to register images taken before and after surgery or before and after treatment. So these are some of the pre-processing or treatments we need to do for these images. And as I said in the previous slides, the region of interest need to be identified. If I'm going to talk about or research about the tumor region, then we need radiologists to segment those regions. And if we are working on some of the infections in COVID, and we need radiologists who mark those regions and say these are the regions that are infected. So there's a lot of pre-processing that happens before the data is even ready for any processing. So the next stage is the pre-processing. The images need to be sharpened, or if you're resizing the images, or margin elimination or margin sharpness, or if you are going to extract any features from it, like for example, if you want to extract the shape features or texture features. So all these features are extracted in the pre-processing stage. And next comes the actual model training and validation. Nowadays, you might have seen a lot of research going on machine learning and deep learning techniques being applied in medical problems. So the major difference between machine learning is trained on features or handcrafted features that are extracted from those images. But deep learning is automatically learns its own features from these images. And the next stage is prediction. What do you want to predict from this image? Do you want to predict whether there's a cancer or not? Or do you want to predict is there any abnormality? Or are you going to predict whether the patient can survive? Or are you going to predict whether the cancer will recur again? Or is there a possibility of recurrence of cancer after treatment? So there are many things you can predict based on your study design. And there's a lot of statistical analysis you can make, like how accurate is your model, how sensitive is your model, can your model generalize for independent data set. So there are many techniques you have to use to validate the model what you have designed. And the final step is model deployment. So once the testing is done in the lab, maybe after a few legal approvals within your university, and it can be implemented real time. So one of the project what I'm going to discuss today, so we have gone through all these stages of AI pipeline, and we have also tested it's working in a real-time environment. Yeah. So this is the overall pipeline of any AI system. So as I told you earlier, today we will discuss one of the one of my previous projects named as Automated Image Quality Evaluation of Structural Brain MRI using an ensemble of deep learning networks. So as the title goes, it's a research project which is aimed to detect the image quality of a brain MRI. So what's the problem here? So this is a research that has been taken so that we can improve the clinical workflow, right? So what's happening in a hospital or in a MRI imaging center? So you can see the first picture, there's an MRI scanner and a patient is being scanned. But not all images are very good. See, sometimes the patient may shake the head like this. There may be motion in the head, or there may be some metal that is implanted inside the head. It will affect the magnetic. It may the magnetic field, and it may create some artifacts. Artifacts means some noise in the image, and there are some other artifacts called Gibbs artifact. So even image acquisition may not be good enough for a radiologist to predict or to visually check any disease or any abnormality in an image. So the challenge here is how can we get a good image when the image is being scanned. The good practice is if the image is not bad, there should be a system to say, okay, go ahead, there's no rescan needed. But if the system detects the image is not good, then it should raise a red flag saying, please go for a rescan. The scan what you have taken is not good enough for any radiological purpose. So there's no system to say whether the image is of good quality or not. So far in clinical practice, the image is acquired, and after a few days, it goes to the radiologist, and only after a few days, the radiologist will check and say, oh, the image has some noise. I cannot use this image. So you have to recall the patient again for a rescan, which takes a lot of time and money is spent on all these procedures. So the idea behind is we wanted to create a system which can work along with the scanner, MRI scanner, and once the image is taken, our deep learning system will automatically say the image is good or bad. So this is the ultimate aim of this project. So for this project, we chose a data set called ABIDE. ABIDE dataset has about 1,000 cases of brain MRI image collected from 17 different sites, which I mean it is collected from 17 different hospitals, which means 17 different types of scanners and 17 different types of imaging settings. So it's a very, very diverse kind of cohort. So mostly the patients were autism spectrum disorder, like some kind of brain disorder. So it's very difficult for a patient to stand or lie down still inside an MRI scanner for a long amount of time. So we have a lot of motion and noise in this database. So our model is to detect whether there is a motion or not. So I'm going to show the table that shows the heterogeneity of this data set. And this kind of heterogeneity in a kind is good for training the machine learning models because it can learn different features from different machines, and it can generalize well for images that is taken from different sites. So if you can see the distribution of this data set, the site ID, you can see Caltech, I think it's the California Technology, and these are the different PIT is the Pittsburgh University, Stanford University, Trinity Hospital, Yale Hospital. So these were the places, and the third column shows the different kinds of scanner and the vendor model that was used to scan these MR images. And you can see the size and the resolution of these images. They are very diverse. And this is the kind of data that has been used for training our deep learning model. As you all may know that before we train a model, we split the data into three sets, right? The training set, the validation set, and the testing set. So even here for the Abide data set, we split them into 60, 20, 20%, 60% for training and 20% for validating, and a separate 20% for just testing the data or testing the model. And yeah, another important technique is data augmentation was applied to the training set to increase the training sample. And it was done to prevent overfitting. So this table shows what kind of augmentation we did, like rotation, shifting, flipping, and zooming. Just a note about data augmentation, if you're not familiar with that technique. Okay, you can see a cat, right? Even if a cat is tilted left or tilted right, it is still a cat. Or if you flip it down or zoom it or stretch it, it's still a cat, right? The same technique is what we are going to use in our database. Even if I'm going to rotate, flip, shear, the data is still the same. So, which means I'm just adding some more data to my data set. Like if I just flip and say I have one more data to my data set, like I can zoom it, I can add some noise, I can brighten the image. So these are some of the techniques that was used so that the network still get more information from the data set what we have in hand. So this is the overall block diagram of the technique. The 3D MRI volume, the brain volume, was actually split into three planes: the axial plane, the coronal plane, and the sagittal plane. And each plane was separately trained using a deep CNN model, and then a fully connected layer was used to classify the output. So similar way, the coronal planes and the sagittal planes were trained first slice-wise, and then they are combined volume-wise for the quality prediction. So for training these models, we used Python using Keras library, and TensorFlow was used as the computing backend. Training was performed using 4 NVIDIA Tesla GTX GPUs on the Maverick cluster at Texas Computing Center. So I'll discuss more about the Texas Advanced Computing Center in my last slide. So as you all know, this imaging data is a big data, and we cannot process using our laptops or our CPUs. We need very speed supercomputers to process these images at a very high speed. So we need high-speed GPUs for processing these or training these models. So this is just a screenshot of the proposed CNN what we use. As you can see, it's the data is read 2D, and then it goes into layers of convolution and pooling, and then there is a final fully connected layer, and then the output is image quality range, or whether the image has noise or not, or in other words, I can say whether the image is good or bad. Yeah. So this is some of the output. The first row, you can see my values are very much less than 0.5. I can say 0.005. Anything that is very closer to 0 is classified as a good image. And the quality score above 0.5 is classified as a bad image. So even visually, you can check that the second row of images are very bad, right? So they have different types of noise in the image. So this picture I'm showing just to say how good the model is for predicting the image is good or bad. So we don't have to wait for a radiologist after 2 or 3 days to say whether the image is good or bad, or not even a technologist has to go through the scans. Just passing the images, all the images, like maybe if you have few hundreds of scans taken per day, so just going interfacing this model to your MRI scanner automatically says whether the patient or the scan is good or not. So if the scan is bad, the patient is allowed for a rescan on the same spot. So a rescan is taken instead of waiting for days to recall the patient for another scanning. So this is how the quality was predicted, and this actually falls under a project that helps in the smooth running of the clinical workflow. So this is another graph showing the quality of the images. Now you can see the dotted lines shown. The first graph shows the axial planes, the image quality score of the 32 slices taken from an axial plane. So all the dotted lines shows those images are good because they are below 0.5 and above 0.5 is the bad images. So those images which I showed earlier is what I am plotting here. The previous picture you saw you're seeing it visually, the scans, but here I'm just plotting those values for 32 slices, not just one slice, the 32 slices that's been fed into the network. Now you can see all the slices are predicted correctly. So even for the axial, coronal, and the sagittal plane. So this figure 5, what I've shown on the right-hand side is the ROC curve of the training. You can see the AUC is very high, like 0.9. If I combine axial, coronal, and the sagittal plane, the overall accuracy or the AUC is 0.9, which is a reasonable accuracy for any clinical tool. And this tabular column shows a comparison of our work when compared to the same kind of work that has been carried over earlier with handcrafted features. So you can see the first few models are trained using machine learning techniques. And our model, without handcrafting features like using deep learning models, can equally perform well like other models. Like the overall accuracy is about 0.84% and the AUC is about 0.90. And actually we extended this model and tested it in real time. We interfaced this machine learning model to the scanner and tested whether the images that's been scanned or sent to the model, and it is classifying it as good or bad. So this is a real-time experiment that was carried out in our lab last year, I think before that year, 2018. Yes. So that was one of the interesting projects we did. And another project, as I said, I will discuss today is again related to clinical workflow. But this is the aim of this project is for MRI safety. See, for example, if a patient is sent for scanning in an MRI machine, there should not be any metal devices. You can see that all the patients will be removing their watch and all the metal things that is attached to their body. But sometimes some patients will have some devices implanted inside the brain. It is metal and it is dangerous if they are not checked properly and they are sent inside the MR machine. So usually they carry a card which says what type of device is implanted inside the brain. But most often the patients may lose the card or they don't know really what kind of shunt valve is in their brain. So a technologist has to go through different protocols to check whether the patient is safe to send them inside the MRI scanner, or should I wait? Or there's a lot of confusion that happens whether the patient is eligible for an MRI scan. So what we thought of is streamlining this clinical workflow by creating a mobile app. So once a doctor takes a picture of the MRI or the X-ray scan of the brain, so the app itself will say what type of shunt valve is kept in the patient and whether this shunt valve is safe for an MRI scan, or is the patient not eligible for an MRI scan. So this is a workflow diagram. You can see from the beginning, if a patient arrives to the MRI facility, the screening process is done to check whether there is any implanted devices in them. If there is an implanted device, then if there's no implanted device, then they can straight go for the MR imaging. But on the other hand, if they detect some implanted device, the usual method is the patient has sent back home to bring the implant card, or the radiologist should spend time going through different database to check what type of implant is inside the brain. So if the implanted device is known by the patient, again, the radiologist has to go through some safety database to see whether it is safe or not. And then only if it is safe, he will allow for a MRI scan. If the implant is not safe, then the radiologist will not proceed with the MRI scan. So what we thought of this workflow is, why not a radiologist take a picture? Because everybody carries a smartphone nowadays. So why not just take a picture of just an X-ray of the implant device in the brain and see, and from that X-ray, use a smartphone to take a picture. So the app that has been already trained with deep learning models will automatically say, okay, this shunt valve is of this type A or B or C, and it is safe. Just allow the person to go in for a scan. So that's the ultimate aim of creating this mobile app using deep learning technique. So the patient or the radiologist or a technologist just use a mobile phone to take a picture, and that app or the application will say whether the patient is safe or not. Okay, so this some of the database, different types of shunt valves you can see, examples of CSV, SV, X-ray valve images in the data set. So each row shows 5 random types of valves. The first row is the Codman Hakim. It's a kind of shunt valve. Row 2 is a Sophisa Polaris. And third row is a Strata NSE. So these are the names of different shunt valves. Now you can see it's this is a X-ray of the patient's head or the brain, showing the plant implanted inside the brain. So all these brands are currently used in the US. So we have been training these pictures or these images taken from mobile phones, and training using the similar model that I showed earlier, right? VGG model. The architecture follows is inspired by the VGG 16 model, and we found good classification, right? The model can accurately classify different types of valves. So you can see I've compared 2 models here, and this B, right? The figure B is the recent model we have proposed. Now you can compare this confusion matrix with the previous one. We can see good improvement, right? Like a classification accuracy of about 0.87, 0.97, 95, and 90 for the different classes of shunt valves. So this is the ROC curves of the training of using these different images. What I want to say is this project mainly want to develop a model which can say whether the patient, the implanted device can be correctly detected, and it will help in decision making in the clinical workflow. And an extension of this project is not only to detect whether the X-ray has a valve or not, it can also be extended to detect different objects inside the brain, like if there's any reservoir, or if there's any distal catheter inside, or ventricular catheter inside the brain. So each and every object can be detected. So you might have seen examples in many of the deep learning examples, like given a road scene, the model can detect whether there's a car, or is it a tree, or there is a bicycle. So different objects can be detected. So there are so much of experiments and research going on in this localizing these objects. The same concept we try to implement in medical imaging to check whether the model can precisely say what other objects are present in the brain other than the valve. So this is one of the output of the model. This is just to check. The first row shows the shunt valve or the strata NSE valve. The second row is the output of the deep learning model. So this image is called as a saliency map, which shows highlighted regions where the learning has taken place. So you can see it's interesting to see these are the pixels that have great influence on predicting this type of class. So that's the advantage of deep learning. It automatically learns by itself. So it says if there is a round white image, then that's strata NSE. That's how it learns. So you can see how the network has learned. All the regions highlighted in yellow is the saliency map. So these pixels were influencing the classification. Maybe if you can go into my paper and see, I have same image type for the other types of valves also, how the network detects these features automatically. And it's quite interesting to see how they work so that they can predict different classes. Okay, so moving on to the next project, since we are running short of time. Okay, so this is another project where we have used the brain and lesion segmentation, where we have used a fully connected neural network for segmentation of different brain and lesion regions in multiple sclerosis patients. Okay, so I'm just concentrating on the results, so you can see how this AI is helpful in medical research. See, these are all brain MRI of multiple sclerosis patients. Multiple sclerosis is again a brain disorder. So ultimate aim is we want to find where are these lesions or the tumor regions. So you can see A, B, C, D are different imaging modalities. Yeah, it's a kind of imaging like proton density weighted. A is the proton density weighted image. B is another type of modality called T2 weighted MRI. This is flare. C is flare image, and D is T1 weighted image. And we use all these kinds of image depending on the experiment. We can use these images to see where is the tumor region or where is the lesions. And if you can look closely, this is segmented by an expert like a radiologist with the help of a tool, of course. And there are certain projects where radiologists do segmentation without the assistance from an expert tool. But here for this experiment, they have used an MRIAP tool, but it was validated by the radiologist. So it is something like a radiologist created this pattern, like this is where the white regions or the white matter regions and the gray regions or the gray matter of the brain. Cyan is the cerebrospinal fluid, and the light red regions are the lesions. This is what the radiologist marked. And surprisingly, if you can see the F, this is what is marked by the convolutional neural network. It performs exactly the same like a radiologist. After training the model, if you can compare a human segmentation and the machine segmentation performs better, at least the same, or in many cases better than human segmentation. So that's why we go for, that's the power of networks. See, suppose if I want to do 1,000 or 2,000 scan segmentation, how long will I sit and do a segmentation, right? It may take few years to finish segmenting these images if I'm going to do it manually. But using these techniques, I can identify clearly where these lesions are. The pink regions are the lesions. So I can say, yes, this patient has lesions and this is the stage of cancer or the type of lesion, and this is the kind of treatment. So any kind of prediction or analysis can be made using these techniques. So these are again some of the slices taken from different patients. You can see the first row has 4 patients. So the first row is done by the radiologist. The middle row is predicted by the fully connected neural network. And the third one is the imaging. It's a flare image. So you can see in the flare image, the white regions or the lesion regions. whereas the network in the second row already predicted, okay, this is the lesion region I can see. The same way it can highlight to equally to radiologists. It can do a work same way like a radiologist can do. So here we have a dissimilarity coefficient of the lesions, and it's pretty much good to see that it's more than 85%, right? Which means that it very well aligns with the radiologist's outcome. Okay, I'll quickly move on to how AI is applied in real cancer research. Cancer is quite unique and it is different from other kind of image processing because the genetic properties of the cancer cells are highly variable, and it differs from patient to patient because of the genetic properties. Even targeted therapies fail, the chemotherapies fail, even with very well targeted drugs, because it's cancer is more patient specific and the tumor region is highly heterogeneous. Even with promising immune therapies, only 10% to 20% of patients show good response. Hence, approaches to characterize and quantify these tumors is a great challenge. And it is very much needed and useful for guiding different therapies to adapt different courses of treatment for individual patients. So in my lab at MD Anderson, it's a cancer lab. As I said, it's MD Anderson is a cancer center. So most of our projects and most of our clinical applications are concerned towards cancer research. So this is a typical radiomics workflow. You can have images. So the first step is we segment the region, whether we want to talk about the breast cancer, extract the breast tumor, or if I'm going to work on a lung cancer, what kind of image I want to extract from it. Should I extract the tumor region or extract the lung region, or if it is a thorax or the head and neck region? So what kind of images or the information I need, what I need to segment from it. So once the regions are segmented, we look for the heterogeneity within the tumor region. So you can see different colors, right? Different colors shows different partitions inside the tumor. So these features are used as an input to a machine learning classifier, and based on the outcomes, I discussed about the outcomes earlier. It can be a survival outcome, or it can be whether the cancer is going to recur again or not. So many outcomes you can design to develop this model. So this is the radiogenomics workflow. Now we have genomic data available and we have imaging data with the information extracted by this deep learning models. We have rich features that is available from the acquired radiologic images, so that we can combine everything what we have, the features extracted from these images, and build a model and use it for analyzing or classifying. And the endpoints, as I said, whether you're going to predict the survival of the patient, or you want to grade the stage of cancer, whether it's in the first stage or second stage, what is the tumor growth, or what is the level before treatment, after treatment, or what kind of prediction you want to make. So so this is how the cancer radiogenomic workflow goes. So as I told you, the tumor region is not a homogeneous object, like it's not a single region. As you can see, you can have multiple sub-regions inside the cancer region. So this heterogeneity is used for dividing the nodules into different habitats, like this is a high-risk region or a low-risk region, or what is this regions inside the tumor model. So it's like digging deeper into the tumor model and see how each sub-regions help in predicting the outcome. And this is a pictorial representation of the habitats what I was talking about. So this T1 flare and T2 are different imaging modalities. So here I'm trying to cluster these different voxels with different specific colors that reflect the different microenvironment inside the tumor. So it's called as the habitats. So you can see maybe just in the imaging, all the tumor region looks white, right? Somewhat white and bright white. But when you subdivide them into superpixels and then analyze deeper, you can see the heterogeneity inside the cancer region, right? It's not all same. Some are very high risk and some are with low risk regions. So this is called as the microenvironment region, where we cluster the voxels depending upon the color, and then like see how these different subregions inside the tumor helps in predicting the outcome. So this is an overall block diagram, give an idea about what I'm talking about in superpixels. This is a breast cancer image of patients in the first row. So these are divided into superpixels, which means they are divided into subregions. And the third step, population level clustering is done so that the entire tumor region is divided into partitions, like it's called intra-tumor partitions. So this is a region inside the tumor region. So we are just going in with like a magnifying glass. You are going deeper into tumor and see not whole tumor is the same. You still have subregions in it, and these subregions specifically can help to predict the tumor response. And I'll just directly go into the results. So here you can see the first row shows one patient and the second row shows another patient. And you can see the clusters, what has been divided. And the last column shows the population level clustering. And to easily understand, I can say red is a cluster A, green is cluster B, and C is cluster C. Sorry, blue is cluster C. Okay, so how is these two patients differing? See, I can see a lot of red here in the second patient and less red in the first patient. So will that help in detecting the prognosis? Yes. So you can see that in the table listed below, the tumor burden of cluster A is 8.9, and the tumor burden of cluster A is in the second patient is 21.7. So there are many other parameters, the SUV and MTV there, but I'm just talking about these clusters, whether these clusters help in detecting the outcome. Yes. See here, you see the region A in the first image, the red region is only 8.9 ml, whereas here the tumor burden of cluster A in the second patient is 21.7. So which already predicted that this patient is going to die in 3 months because the cluster A has tumor burden, whereas this patient can live for long years. Actually, the prediction is correct. The patient is alive after 4 years. No progression in the patient, cancer progression. But this patient died after 3 months because the severity of the cluster, this region is very high, and it has been already predicted. So this is how the tumor is segmented and features are extracted and to see whether the patient survives or not. And the same kind of experiment is repeated for a perfusion MR imaging to predict recurrence, like whether the cancer will repeat or not, and whether the patient will survive or not for advanced breast cancer treated with neoadjuvant chemotherapy. And this paper was published by my lab PI, Dr. Jiawu. That's his main work, mainly involves in cancer treatment and prediction. And his work is mainly on the breast cancer, and similar habitat techniques were applied to identify the heterogeneity of the tumor region. And you can see some of the features are extracted, like 22 features, quantitative MSI features were extracted from these tumor regions in the breast. And again, two patients are compared. Now here you can see the burden of this. The red regions are called as the red high perfusion subregions. So here you can see two patients, I will directly go to the features, MSI features. Here you can see all the MSI features are low, whereas all the MSI features are very high when compared to this patient. So, which means this patient has low risk of repeating cancer. Like the cancer has gone, but there's low risk of cancer coming back. But there is a high risk of cancer repeating in this patient because of this, because of how the tumor looks like in the imaging. And the outcome is correct, right? The outcome of the patient is he is recurrence free after 355 weeks. Even after 355 weeks, the cancer did not return back, whereas there is a distant metastasis, which means the tumor has grown back after 216 days, 16 weeks. So this is how we predict whether the cancer is of high risk or low risk, or whether the cancer will repeat or not. Okay, so that's an overall idea about the cancer researches going on in our lab. So as I said earlier, we need high supercomputers for all our processing, and our labs are inbuilt with high speed computers with GTX GPUs, right? And also we use Texas Advanced Computing Center is in Austin, Texas, and that's a center dedicated for computing services. And all the Texas Medical Center computations can be done, research works can be done in that center. So we usually virtually connect to their machines, and we can run our programs training different models for our analysis. And you can visit their website, TAC website, to learn more about the center. And another technique we usually use is Docker. Docker is a platform as a service product. It's operating system independent software. So all the packages can be put in a container, and all your programs can run in any platform. So that's a technique we usually use. And these are some of the medical imaging tools which are useful for our everyday analysis, like FSL tool for fMRI, MRI and DTI brain imaging data for registration and for classification. And we mainly use ImageJ. ImageJ is an image processing software for 2D and 3D images for filtering, edge detection, resampling. And if you want to view a 2D DICOM image, it can be visualized. ITK Snap is another very important medical imaging software that is used by a lot of radiologists for segmenting the structures in 3D medical images. And we have 3D Slicer. It's a tool useful for segmentation and also visualizing. And if you want to convert a PET scan to SUV format or different formats, so these are some of the tools we use every day. And the common programming languages we use is Python, MATLAB, R, and Java. These are the tools we use for our programming. And these are some of the references what I have used in this presentation. And so I need to acknowledge some of my previous lab members and current lab members. And yes, thank you so much for your time. And if you have more questions, and if you want to know about the opportunities to work in medical center area, or if you have any questions related to software or hardware in medical imaging, feel free to send me an email. And I really thank you all and your management and the IT team and the organizers for giving me an opportunity to share my experience with all of you. Thank you.
Thanks a lot, Dr. Shiva. That was a mind-blowing presentation. I was literally not able to move out of my chair all through the presentation. It was very interesting.
Thank you.
Lot of medical jargons. I mean, the technical part of it is fine, yes, but the medical jargons, sometimes I had to actually Google around and see what was it actually meaning. And I was taking down a lot of questions, but I did notice that almost all my questions have been answered through the presentation, Doctor.
Thank
Thanks a
you.
lot. But we do have a question here, and the participants, please do feel free to post your questions here. We already have a question. Perhaps I can share it with Dr. Shipa here.
Okay.
The participant says, "Hi, Ms. Shipa. How common is it that the CRI images are not usable?" So it's based on the first project that you shared with us. So how common is it that these images become unusable, doctor?
Yes, it is. It's a very good question. It's not like every day all the scans are corrupted. Like maybe 10 to 20% of the scans that is taken are with this problem. But that's a lot of cost involved in rescan and rescheduling and then re-diagnosing the scans. So it is very much usable for a clinical purpose.
I see. All right. Great, great. That's great. And a few pointers, perhaps, Doctor. These questions, I guess, might help the students and participants who are willing to work in this field of
Yeah.
medical imaging.
I
Doctor,
still see,
regarding,
sorry, I still see my screen. Is there a way I can take it out?
no, it has been taken out, Doctor. It has been taken out.
Okay,
Perhaps you can minimize your presentation if you want to feel comfortable. You can minimize it. Yes. Yes,
okay.
doctor. So here, regarding the tools, doctor, regarding this ITK snap, is
Yes.
it specifically used only for medical imaging?
Yes, so far we have been using only for medical imaging. Yeah, it's a medical imaging software.
I see.
ITK.
All
Yeah,
right.
it's only for visualizing medical images in 2D and 3D format. And if you want to register images or segment or convert
Mhm.
image from one format to another format, yes, we use ITK Snap.
All right. Okay. Um, Doctor, you were talking about data augmentation of images, image augmentation, and
Yes.
regarding image rotation, translation, the operations that we do. Doctor, I mean, in your experience, are you using any automated tools that are doing these augmentations, or uh, is there like a lab assistant or someone who would actually do it manually, Doctor? What's your opinion?
Yeah, data augmentation can be done automatically. It's a part of a technique in deep learning. I can say it's a bit paragraph of extended coding you have to do, right? So yeah, it's we can do it ourselves. We don't need a additional person to help you in data augmentation. You
All
can
right.
specify how much you want to augment, like how many degrees of rotation. Everything can be specified. It's everything in programming. You can
Mhm.
you can specify. Yeah, it's not done manually. As if I can answer your question, it's not that
Right.
somebody sits and rotates. No, it's not
Okay.
done that way. It's done on the fly. Like when your program runs, um,
Okay.
you don't even see that. But if you really want to see how your data is augmented, you can. There are ways to visualize the images. But
Oh,
yeah, you don't need any manual intervention to do that. That's a lot of work.
right. That's right. And getting back to the title here, Doctor, I'm quite interested to know something. That is, students, youngsters who are going to learn this domain. On one hand, they are already learning the technical side of programming and image processing or artificial intelligence algorithms, deep learning, and stuff. Now, may I know how did you get to learn all these medical jargons, the medical terminologies? Like, did you have to spend your time sitting down and then studying medical books, or how did it happen to you? Please share your experience, doctor.
Oh, am I too different? I don't know. I don't see it from my side. Maybe I've been working with closely with the radiologists and the oncologists for the past 5 years. I
Okay.
think I have picked up those jargons, but
Jargon.
yeah, I think I didn't sit and memorize these jargons. I don't know what jargons were new to you,
No,
but
I mean, for you, they are not jargons, doctor, but
yeah,
for
yeah,
us, like
yes,
purely
yes,
belonging to the IT domain, we
yes,
find that, I
yes,
mean, the medical terminologies, I mean, for
yes, yes.
non-medical experts,
Yeah, I
they're
totally understand. Yeah, I started working on medical imaging right from my PhD days. So it's been 10 years I have been in medical imaging, specifically on medical imaging. So I think maybe reading articles and then meeting and discussing with the doctors, I have picked up those jargons. Yeah, so yeah, but basically it again comes back to your programming skills. that's the engineering part of our contribution to this medical imaging. Yes.
Thanks, Doctor. I think, yeah, you have really invested on both the domains to gain knowledge on both sides of it. And yeah,
I,
the case studies. Mhm.
yes,
Yes, Doctor.
I still feel it's a long way. It's a continuous learning. I'm still learning. Yeah,
Right.
everybody is learning. Every day is a learning process. So I believe in
Right.
that. So yeah, the learning never stops.
Excellent, excellent, Doctor. Yeah, I don't think we have any more questions here, Doctor. And I was very interested to see all the case studies and the information on the case studies you were sharing. Yes, it was literally a treasure of knowledge, I should say, a very big treasure of knowledge. I'm sure all of our participants here would have benefited from all this valuable information that you have shared. You know, it's all your experience and your knowledge in this domain. I'm sure it's going to have a very big, notable impact on young researchers and
Yeah.
scientists who are going to work in this domain. Last but not the least, Doctor, thanks a lot for joining us today and spending your valuable time from the United States
Yes.
and giving all our participants a very good presentation, Doctor. Thank you so much.
Thank you, Dr. Wazir. And I take this opportunity to encourage all the young researchers. And there's a lot of
Wonderful.
potential in AI and medical imaging. And I'm sure if you start, you won't stop. Yeah, so that's what I feel. So if you find any difficulty in starting, like where to start, what to learn, you can always email me or you can contact Dr. Wazir and you can contact me through him. I'll be more than happy to assist you in your path towards attaining
Definitely.
your yeah
Thanks a
your
lot for that comforting words. Thanks a lot. Thank you so much, Doctor.
thank you.
So, without taking more of your time, Doctor, I'm sure you must be very tired. So, thanks a lot again. So, again, big thanks to all the participants who have joined this live session, and some of you have posted questions. And I guess, as Dr. Shiba says, if you have more questions to talk about, if you want to learn more on this domain, you can definitely reach out to Dr. Shiba to get more information on this domain. And yes, before we end this session, I also want to give a lead to our next webinar today. We're going to have another webinar. It's at 11:30 and it's AI Explained by another very renowned speaker from APU. So thank you once again. Now we are signing off. See you all again at 11:30. Thank you
Thank you.
so much.
Bye.
Bye.